Welcome and thanks for staying this morning with me. What a great morning we've had. Do you not think it's been really inspirational? I'm just pleased that I'm here listening to everything that's happening. Okay, it's really nice to have people from my hospital, but to have friends and colleagues here. So welcome. So I'm Anita. I trained as a physician, as an endocrinologist. I met my mentor 20 years ago and said, I want to be like you. I want to look after pregnant women because they scare me, because they did scare me as a very, very junior doctor. 20 years on, I now work as an obstetric physician. I'm pretty unique. I work in different settings. Last year in COVID, I worked as a general physician, got COVID myself, and managed the COVID wards. This past year, I'll tell you our journey, and the girls at the back know it very well, so I might get you to say something if you wish. So, first of all, every single day, 810 pregnant women die across the world. Okay, so that's the WHO figures. Every 2 minutes, a pregnant woman dies somewhere in the world. Can you imagine? So 99% of that, is in the low-income and middle-income countries. But I would challenge us that in this past year as COVID, we became a low-income and middle-income health strategy. Do you not feel in maternity? We were left with virtual consultations, left with nothing that we're used to seeing. And I think it's been a really, really tough year in our world. Looking at the maternity and looking at actually the goals of maternity and the goals of the developmental goals, the aim is to reduce maternal death by 50%. This fits with better births in the UK, where we want to reduce births death by 50%. However, how are we going to do that? Okay, so in the Congo, it's about 420 per 100,000. In London, in UK, it's about 10 per 100,000. But I would challenge us that because of COVID, things have actually got worse. So we live in the UK. We know about Embrace. Embrace, since 1952, we've looked at every single maternal death in the country, yes? Every 3 years, we were bringing out those 350-page reports, and we kind of got it. For the past 6 years, we've been presenting it every single year to you, 100 pages and lots of infographics, to explain to you that pregnant women are still dying. And in the past decade, it's about 10 per 100,000. Now, all of you are very, very experienced, and what you've realized for the past 20 years is that more women are dying because of medical problems in pregnancy. Okay, your skills and drills for postpartum hemorrhage, your skills and drills for all of those aspects are better, but it's medical problems in pregnancy, and that's why I've got a job. So when we think about why someone's dying and they're pregnant, you've got to think about it in the purple, dark purple, and in the hatched. If you look at the dark purple, these are the medical problems in pregnancy. And right at the top, you will see it's cardiac diseases in pregnancy. Okay. Then it's the hatched, which is venous thromboembolism in pregnancy. And then it's neurological problems. So this is our launch from last year, where we looked at the deaths from 2016 to 2018. We're launching again, as you all know, on the 11th of November this year, and we'll give you the data for the past 3 years again. So if we're not dying of postpartum hemorrhage, and I'm telling you that 3/4 of the deaths are because of medical problems in pregnancy, think about the morbidity. For every single person that's died, think of the 50 that nearly died, and think of the long-term consequences. It was really moving listening to the sepsis survivor, John, wasn't it? It was really touching. And I would say for us, in maternity, what happens to our pregnant women? Even if they do survive, what are we left with? So for us, I think it's this window of opportunity to really understand when they're sick. Okay, we expect a pregnant woman to be healthy. Okay, those who know me know that I'm always looking for the, raised BMI, diabetic, hypertensive, socioeconomic class 4, 5, alone, lonely woman, because that's who I want to look after. Even so, young people are still pretty healthy. We do not have what we have when you're 80 or 90 years old, slowly deteriorating. What we have is you have a heart rate of 100 or heart rate of 90 to 100, and then suddenly it's 150. You've got no give, and that give, I commend you, particularly the midwives, because the job that you do, you are there with that woman all the time, and they can change so quickly. So we've got to really understand this window of opportunity better, and I'd say I've spent the past 5 years looking at this in a little bit more detail, because yes, it's sepsis, but it's also preeclampsia, and then it's all the masqueraders of sepsis and the weird and wonderful that you only know on the post-mortem or if you're lucky, you've picked it up a bit later. So, physiology of pregnancy. I'm not here to teach you. I promise you, it's not a webinar of teaching. But you've got to remember two things: cardiovascular adaptations change everything. So, if we start with at the end, if we think about cardiovascular adaptations, it's happening in the first trimester. Okay, there's things going up, there's things going down. All you've got to remember is that heart has to work harder. Okay, we are stressing ourselves when we are getting pregnant, believe it or not. If we think then about respiratory rate, there was a really nice paper from the Oxford group about 2 years ago, which looked at 300 women and followed them through all trimesters and postpartum and looked at what actually changes. And this was published before COVID. And what I've shown you here, to remind you, respiratory rate does not change in pregnancy. If your respiratory rate is raised, if you think they're sick, that woman is sick. And that's really important because sometimes people don't listen. There's that clinical inertia. There's not that urgency. And how do we get that urgency to get it right? So the maternity early warning scores, we've learned about News 2, and hats off to Matt. I think he's an incredible driver of this and really developed News 2. But that was in non-pregnant patients, yes? Thousands of them, and very well set up outside of maternity. Everybody uses it. Everybody understands what to do. But what have we got in maternity? Now, our Muse chart, as you know, there's a different Muse chart in every single hospital in the country. Okay, Scotland, 2018, 5 million population, changed to a national one. Yes? Ireland did it even earlier than that and changed to national one. Where are we? Where are we in the UK, and how are we going to get this better? So in London, we looked at our news charts just pre-COVID, and we had 26 of them. I mean, what's the point? What is the point of looking at different numbers and then having discussions and having unfriendly discussions with our colleagues, really, about is anybody interested? Is anybody going to escalate this? You'd be pleased to know that I'm working with Matt and everybody else to make a national MEOWS chart, okay? We're currently in prototypes. Hopefully we will be launching it next year. And let's embed it, and not embed it in just 60%. Every single maternity unit that all of us work in, we've got to use it at the same time, because that's the only way we're going to get it right. So what is different about a pregnant woman? If we think about the ABCD approach, airways, now you know they can be more inflamed, laryngeal edema because of preeclampsia, because of vasodilatation. We have learned 25 years ago we don't want the ST1 obstetric anaesthetist to actually do the general anesthesia on our pregnant woman. You want the most senior person there to anesthetize them. Okay? When we think of breathing, I'm going to remind you again, because I have no shame. If the heart rate's up, you've got to worry. You've got to think straight away. The word anxiety does not exist in healthcare. Okay? You're meant to be anxious. That's normal. That's not an illness. And we should not write those things anymore in our notes. Circulation, you know the blood pressure goes down a little bit in pregnancy. If it goes up above 140/90, my God, you're all so good at managing it. You can do preeclampsia with your eyes closed, okay? So how are we going to do it with other conditions and other conditions that you are going to see more of as the landscape of obstetric has changed? And then if we think about disability and diabetes, every woman has diabetes. That's what it looks like. I'm a diabetologist by trade. But we have about 15 to 20% of our women have got gestational diabetes. I've got about 800 women in my clinic every week. That's too many, okay? So obesity has to get better, yes? And health has to improve for our pregnant women. And then 20 weeks, so aortic compression, okay? You know yourself, lie them flat, they will faint. You've got to think about that. And when you're in an emergency, resuscitation has changed now. If you can't get them better, so a woman has arrested and she's pregnant and you don't get them better in the first cycle, you've got to make sure somebody's ready to remove this baby to give that woman a chance to live. And we've got to change that really, really rapidly if we're going to make a difference. So where can a woman present? I've actually used the WHO emergency framework to tell us. And I know it looks really busy, but I think it's fascinating. If you start from your end at the back, you think about the community. Okay, and it doesn't matter whether you're in rural Africa or you're in the middle of somewhere in the UK. You are somewhere where your point of care is not equal. Yes, everybody's too busy to manage something. We all can have our heads in the sands, including myself. And how are we going to get that right? I do believe that having a national and having a Muse chart that everybody agrees with is important. But when you're in the community where you're somewhere you haven't got a SATS monitor, that's not very helpful, is it? Okay. Then you've got to think about our pregnant woman is everywhere, isn't she? She's not just in Sainsbury's shopping. She's at GP, she's in your community clinics. She could be anywhere, and even in a non-co-located maternity unit. So you don't even know about her, but she's in the hospital literally 200 yards away from you. Then the ambulance service, there's a really brilliant ambulance talk happening downstairs concurrently that you can listen to later. But we've done a piece of work with the ambulance service because they need to help us, and they continue to help us to bring our women to us to support us, yes? And then if we think about our hospital settings, we all work in different places. And where we work, is it fit for purpose? In this place, post-COVID, when we are resetting and recovering, have we got it right? Shout out, okay? You know about the Ockenden Review. You know about all the things that are happening in maternity, and only we together can actually make a difference. So I talked about pregnant women can present anywhere. So as I said, I'm a physician. So with the Society of Acute Medicine, which is SAM of SAMBA, we actually did a bench audit pre-COVID 2019 to look at where do pregnant women present. And if I take you again to the busy graph at the back with the two arrows, pregnant women actually really present most commonly in the maternity assessment unit, or they'll present to the ambulatory care not in maternity. Okay, so you've got physicians managing them, and sometimes you don't even know that they're down there. And what's really interesting, and you can't see it, but you can get this paper, you can download this paper, and I'm very happy to send it to you. They present with query PE, query hypertension, and this is what they're presenting. They can present with anything. In that day, because it was one day that we audited the whole of the country to see what pregnant women were presenting and where and what symptoms and problems they had. Obviously, it varied from having malaria to having a bleed to having cellulitis, but the most common things actually were the things I was saying, shortness of breath, palpitations. So we need to know, are we really worried about the shortness of breath and palpitations? And more importantly, in your own maternity unit, do you need to know what's happening downstairs, yes, with them? Because remember, they're using News 2. They're looking at the News 2. They're not looking at our numbers. And do they realise that blood pressure of over 140/90 is abnormal? Have we asked them? Have you asked them? You're nodding, yes?
We have the news down in A&E.
Fabulous.
We've done a lot of work within maternity and A&E to ensure that when our patients come into the A&E, they use news.
Wonderful. And where is that hospital?
That's
Yay! Southeast London, once again. Love it, okay? So how do we approach a critically unwell patient, okay? And let me take you through this. If you start at the end again, you've got to think about what are they presenting with? What are the red flags? Then you've got to think, have we actually identified them? What is that lag period of identifying them? Then we've got to think about what setting you're in. Are you in the ED? Are you in community care? Are you with the GP? Or are you literally in a room on birth centre, but we just didn't know about you? Let's be honest, that can happen. Then you've got to think, who needs to be involved if we think they're sick? What are the markers and what are the quick things we can do? What's our point of care testing that every single one of us can do? And we were having a conversation about workforce. We really need to get this right. We really need to make sure point of care testing is easy, simple, and anybody can do it. And if it's non-invasive, make it smart, but make it accessible for all of us to use. Agree? Yeah. Okay. Lactate. I love the venous blood gas. I think every single one of us should know how to interpret a VBG. Do you agree? Thank you. Okay. So, get it out there. Let's make sure every single person can interpret it. Lactate of 2, start worrying. Lactate of 4, call everybody. Don't even waste your time trying to sit somewhere. Those of you who know me, I've got a 20-minute rule. Okay, if it's not done by 20 minutes, I'm there, aren't I? So, but you've got to keep ticking like this if you think they're sick. Once they're not sick, you can step back and you can do the care that you need to do. So I believe in the Muse chart. I really do agree that the scoring will help us. But I think there's also behaviours and there's an understanding of life in healthcare, and particularly maternity at this moment, that we need to get better. And I think the human factors actually are the challenges that we lead. And I want to just discuss that a little bit more. So in South East London, for the past 5 years, we've been running a simulation course, which is a high fidelity, 16 health professionals at a time. It's a mixture of midwives, A&E doctors, anaesthetists, obstetricians. And what we did was we made a package of having set scenarios that we kind of either got from local understanding of our women or from Embrace. And obviously things like sepsis, stroke, etc. And then we actually asked these 127 people that we first assessed this on to say, okay, so what did you learn from this? Okay, what didn't you know and what do you know now? And it was important to be up to date. Yeah, up to date in a way that is important. I mean, I don't know about you, but I'm webinared out. I find podcasts now more interesting because I can do that while I'm walking and running rather than sitting in front of something. So we've got to understand how we're going to update every single one of us all the time. The truth is we can't, okay? But we've got to do it in a way that we've got enough people that will know and put their hand up and say, you know what, this is now how we change this, and this is what we need to do. So then the 3 arrows in my table here, closest to me, actually tells us that people were more well-informed about sepsis 6 and felt more comfortable. They were more well-informed about Embrace and knew about the Embrace that we were presenting. And they felt as if they'd learned something. And we did a post-survey follow-up of these people about 3 months later. And they did say things like, Anita, I put my hand up and I shouted because I didn't think it was postpartum hemorrhage. This did not look like a typical obstetric emergency. Something else was going on. But I think there's more to do than that. And this is where how we use Muse and behavioural is really, really important. Now, I appreciate this is really busy, but there's 2 things I want to show you. Now, you can see the graph with the bar charts, and I've got them into obstetrics, physicians, and midwives. And if you just look across it, you can see it's very well skewed to your left-hand side. And what this tells you is that when obstetricians, midwives talk to each other in an acute emergency straight away and don't just do their silo working, the outcome is better. So what we did was, now I've run this course and seen about 350 people go through it. We recorded a lot of things that were happening there. And we were not judging the person, we were judging the system. And what we did was we really analysed what was happening to every single scenario and what we could do different. And what we noticed was that where the simulated performance and the outcome was good, the actual leadership was shared leadership, the mental model was the same, and it wasn't a time when the obstetrician was just delegating to the midwife, okay? And when later in that those scenarios, in the middle, we reviewed it again to say, was there an opportunity for the midwife to speak up? Was the obstetrician had gone off on a tangent, okay? And had the other doctor, the physician who'd come in, just disengaged because they were scared? So we really started looking at this in a bit more detail. And what we found was that this is what we've got to get better. When we first turn up to an emergency, the shared decision-making, the same mental model. Now, I know, looking at all of you, and sadly having to sometimes walk into the PPHs and all the things that I don't want to walk into, you guys will go into that scenario, that clinical practice with a shared decision, yes, same mental model, and you know what you're doing. We now are living in a world with medical problems in pregnancy and illnesses that sometimes we walk in and we're not sure what it is, and we need the headspace for it. And I'm going to challenge you all to go back now and think about it when you think about somebody who's not got PPH but who's sick, understanding and being willing to speak, to say, you know what, she looked less grey a bit earlier on. I know she's sick. This is what I've done. And this is the only way we're going to do it, okay? You cannot run in and let the most senior doctor manage it because that doesn't work anymore. And you all know that. So we're going to continue looking at this, the human behaviours. And when the new MEOWS chart is developed, we're actually going to spend the next 5 years, believe it or not, understanding how we're going to change the behaviours with it. Because I think maternity is unique. We have physicians coming there. We have anaesthetists that work down in A&E and then they come up to us. And the number of times they tell me, you know what, Anita, I'm really happy working in A&E. I feel comfortable. When I come to maternity, I'm scared. Okay. Now, if the anaesthetists are scared, think about think about the physician. Yeah, think about that medical registrar, how they feel. Okay. And then we've got our own world of obstetrics, where we are, you've got mother and baby, and it is not easy to manage everything all the time. So decision-making has to be together, but it is all about the mother and the baby. So we're worried about the baby, yes, and the timing of delivery of the baby, and we're worried about the mother, and we're worried about what we're going to do with her. And I think we've had real ethical challenges with COVID this past year. And I would say we've had more iatrogenic births than we have had previously, because I think we've just bailed out because we've just been scared. Also, I would say, and including myself, we've actually bailed out because we've thought we can't do anything else, because in that first surge, we had nothing else, did we? We had oxygen and intubation. We had nothing else to offer those women. So let's talk about maternity and COVID. So for those of you who know, there are 2 reports that we look at for maternal deaths during COVID, HSIB and Embrace. So they've been looking at these things, okay? The big thing we learned was that in the first surge, women didn't want to turn up. They were too scared to come into the hospital, yes? Now we've got the opposite. Everybody's coming in, and we still haven't got the resources now, have we? We haven't got the workforce to look at everybody in a timely fashion, okay? You know what the risk factors are for having this, yes? Okay, so being of ethnic minority, BMI of greater than 30, being over 35. But honestly, I would say not having a vaccination is your biggest risk at the moment of not having COVID. And how are we going to change that? Okay, because prevention is better than treatment. And the UCOS, the one straight here in front of me, you can see on your right-hand side, is the latest UCOS data of all the women that had COVID between February last year and literally September this year. And what's really, really sad, we lost about 9 women in the first surge, okay? We lost about 11 in the second surge. And in this third surge, we're all tired, we haven't got the workforce, we've got a vaccination, we've got more deaths. 17% of women make up the intensive care admissions at the moment across the country. We've had many women on ECMO. We always seem to have a pregnant woman on ITU with COVID at the hospital that I work. And what are we going to do about this? How are we going to change this? 47% of the deliveries that have happened so far have been a cesarean section. So that's way higher than what should be the national average. So can you see, COVID and pregnancy has pushed us far greater than we ever wanted to. So let me share this case with you. Some of you will know her. So Sabrina has allowed me to share this with you, but she's a 29-year-old lady, and she's staying with her mom. So she's booked at another hospital, but she's staying with her mom. This is surge 2, and we've got the lockdown again. So she's presented with reduced fetal movements and symptoms, and she comes to our maternity assessment unit. So she has her swab, she's safety netted, and she's explained, and she's been informed about the red flags. If you get more short of breath, if something changes, come back in. So then on day 9, she has fever, she has a cough, and she's more short of breath. What's really interesting, yet again, she's been short of breath for more than 24 hours, okay? Because nobody wants to come in at 9 o'clock on a Monday morning, do they? They want to wait until about 7 o'clock when the partner comes in and, it's a little bit quieter. So anyway, when she comes in, she's a little bit hypoxic. So the PO2 in pregnancy, oxygen consumption increases. So it should be about 13, 14. So hers is 10.24. Her lactate is 1.15, so we're all kind of happy. But remember, lactate and COVID, 2 different things, particularly for our pregnant women. She's got a sinus tachycardia. Heart rate is 120. She's got a respiratory rate of 30, which is raised. Her uterus is soft, so we think, okay, she's got COVID, she's got chest x-ray changes. Let's give her some prednisolone and let's see how she comes. Give her some thromboprophylaxis. I must let you know she's 33 plus 2 weeks pregnant, okay? So then 6-7 hours later, we get informed that actually she's now desaturating. So when she walks to the toilet, her SATs go down to 90 to 93. Her work of breathing has increased. So her respiratory rate is about 40. And she looks about 20 years older. This woman looks about 20 years older. So we give her steroids that night. We give her steroids in the morning. And it takes us about 3 hours the next morning to actually get everybody together to deliver her. and we delivered her the following day. Let me share with you what she said, and this is Sabrina and Amelia.
So just a quick voice note on my experience. So once I contracted COVID, I pretty much felt as though I was deteriorating very quickly. And by the time I got into hospital, my breathing was incredibly hard. It was hard to breathe. It was hard to just do short trips to the toilet, to the loo, without, getting really out of breath, not being able to breathe. And then I think, I had a really, really bad state. And it was such a good decision to get my baby out, which was you, Amelia. Because I remember the procedure, and literally as they, after during the tugging bit, and then once the baby was out, honestly, I could just breathe. I just took a deep breath, and since that moment, I remember everyone was congratulating me, saying that I looked so much better. It was literally as though I could breathe again. So it was so good to have had the baby out, and she is now healthy, as you may be able to hear her in the background. So thank you so much for that, and for your support and your help.
Okay, so we got it right then. Okay, so we understood she was deteriorated. We delivered her, and she suddenly got better. I mean, it was phenomenal. Literally, the baby was pulled out, Amelia was pulled out, and she could breathe. But do we get that right every single time? And how do we get this right? And what are we going to do as the obstetric landscape is changing? So the peer framework you've heard about today, okay, and it's so important, that planning, prediction, identification, escalation. And I would say for COVID, this is what we've been working on. So we predict it, think about the women that are going to get it, identify it and get that diagnosis right. Escalate it, and we're going to talk about the escalation pathway that we worked on at Tommy's. And, who do we escalate to? The response that we give, and the response has changed, hasn't it, in the past 18 months, really, because really we've got better drugs, haven't we? We've now got not only oxygen, we've got the steroids, and it's prednisolone, not dexamethasone. Yes, because dexamethasone too much for the baby. If we give repeated amounts, you're going to get brain volume reductions, and we're going to end up with neurodevelopmental problems. So steroids only for the lungs, okay, and only the obstetricians and midwives should be saying that. Yes, medics and everybody should know it's hydrocortisone or prednisolone. Remdesivir can be used, but I would say, tocilizumab is probably more out there. And like I said, we used it last week in one of our women. And then thromboprophylaxis is obviously important, but you know that from maternity. And then, the trials, the fact that we've got these trials, but women were not on it. The fact that in December, when it came to vaccination, there was this kind of scareness, wasn't there? There was this thing about we're not sure whether we should use it on women. And look where we have now, 8 months onwards. What are we going to do about vaccination? So this is really, really important for us to think about, because going forward, how we speak and how the public speak changes actually how our women perceive what is healthy and what's not healthy. So we've got to get that right and be a voice for them. This is the ICNAC data. So the ITU have been presenting data from their database regularly. And again, the graph on your left-hand side shows you the 3 peaks, the wild, the alpha, and then the delta variant. And you can see the numbers that we're now dealing with. So in Southeast London, we had 65 positive in the first surge. Across Southeast London, we had 185 in the second surge. And, we're probably over 800 to 1,000, if not more, in the third surge. I haven't got the numbers for the third surge. And again, these are women of ethnicity, they're women of social deprivation. So we've really got to think about, what is it about social deprivation that is pushing this, and what are we going to do about it? Because if we think it's the NHS and it's equal to everybody, how are we going to make it equal? And then the deaths, I've already said to you, that the deaths are more in this last variant than the other two. Okay, that alone, I think, is what we should be using as language when we say to women, please have your vaccination, because that's not right. We don't expect women to die in this country, do we, when they've had a baby? So the maternity escalation pathway, let me just go through it. So again, it's a traffic light system, and we start at the end. So we think about red, green, yellow, yes? And then we think about the parameters. So we know that respiratory rate is a good marker. We know oxygenation is a good marker. Respiratory rate of 20 now is should tell you that something's not right. And as you go down this traffic light system, what this enables you to do is think about the clinical inertia, because you're worried about oxygen or you're worried about something, but are you worried about everything together? So at Tommy's, what we've said is that anybody who needs oxygen, we want everybody to know. So we want the consultants to know, because it's the consultant's responsibility and the MPL to let everybody else know. Okay, it shouldn't be from bottom up. We should be making sure we are supporting them, whether it's 2 in the morning or 2 p.m. I don't care. The second thing is, what gestation are they? Before 22 weeks, leave them with medics, yeah? Much better. Just tell them everything you want to use, completely safe. After 22 weeks, we've got to look after them. These women have possibly a viable baby, okay? These decision makings need to be made. Neuroprotection, magnesium, you know that's safe and needed if you're going to deliver a baby preterm. How are you going to make sure the medics or critical care know? Who actually draws up the magnesium sulfate? I know the midwives can do it much faster than any doctor. Doesn't matter which doctor it is. I've never seen a doctor draw up the mag like you guys do. Okay, and magnesium is a wonderful drug. So I'm not going to go through this too much, but I'm really proud that the RCOG are using our escalation pathway, and that's hats off to South East London, because we developed it across South East London. But we've done something further. So you heard about pulse oximetry, yes, from Matt earlier this morning. And we didn't have that available to maternity at Christmas. It wasn't available. So actually, for the past 8 months, we've been working with Matt and colleagues to say, well, actually, what about our women? You know, because not everybody can afford a oxygen saturation. More important, even if you've got it, you may not know how to use it because you don't. Yes, there's lots of reasons why you don't. And actually, how do you safety net that? So this is the COVID pathway for COVID and pregnant women, and this is a London ambulance pathway that we've developed with lots of people, so there's lots of people involved in this. And I know it looks complicated, but what I want to kind of tell you is that what you've got to remember, and I'm just kind of highlighting, is that meows, not news too. 94 and below, so 93% is dangerous for pregnant women, okay? And more importantly, the last thing is, if you look at your left-hand side at the top, there is a box with green and yellow, and it's talking about the safety netting and the vulnerabilities. Because our pregnant women sofa surf, yes, so they're living in different places. There's domestic abuse, which has occurred, which means they cannot shout out. There is ethnic variation and language. And if it's not language, it's just like they've lost trust with us, okay? They've just lost trust. So how we need to think about that, and you've got to remember this when you're looking at every single woman. And what we've asked London Ambulance Service and the 111 to do is to think about that too. Not just think at the parameters, but think about our vulnerabilities. And obviously have all the others, you know, if you've got a heart transplant or kidney transplant, worry about those as well. The other thing we've got to think about is that clinical inertia that's occurring and how we're going to change that. So we think about mother and baby. And if you've got COVID, doesn't matter if you're sick or not sick with it, let your maternity unit know. And that's one thing that this community pathway has actually desired, yes? Because again, a bit like this morning, everybody needs to know. You know, GP, urgent care, pharmacists, everybody needs to know. So the maternity pre-hospital escalation pathway was already developed by Amanda Mansfield and the London Ambulance about 5 years ago, and I know she got her MBE mainly because of this, and she's worked really hard on this. And so pre-hospital is as important, but I'm not going to talk about that today because you all know about delivering babies, etc. Clinical inertia is really, really important, and this can happen at any time. And the Acute Care Toolkit, which was developed at the RCP in 2019, thinks about this in the clinical inertia tells you that, women present with symptoms, people present with symptoms. And what our job is to understand and help us, forget Wikipedia or forget anything, how it helps us about the language we use to decide what's wrong with them. And as you know, shortness of breath is way above there. The red flags and the representation cannot say enough. Somewhere across A&E, GP, maternity, urgent care, we need to know when our pregnant woman turns up. And we're not going to know until it's digital, are we? We're really not, I don't think. But we've got to find a better way than what we're doing now. So if you look at the RCP Acute Care Toolkit, you will see that what we've given you is differentials for every symptom. So that if you've got shortness of breath, chest pain, and for shortness of breath, we've kind of divided it into first, second, third trimester. So as obstetricians and midwives, you will know the symptoms and you'll know the worrying things about pregnancy-related problems. What the physicians need to know is respect you for the pregnancy-related problems, and what they need to bring to you is the non-pregnancy stuff and help you look after those things. Yes? And if we do that right, I think we'll get it okay. So I'm wrapping up now, and I want to really talk about the long-term morbidity, because it's not only just that we've got them better, yay, because it's exactly what we heard this morning. There's a lot of other feelings left with this, the cognitive impairment, the psychological consequences, and the post-traumatic stress, and the recurrent readmissions, because you're scared, you think there's something wrong with you. So one of the very first COVID pregnant women that we looked after last year, we ended up referring her to perinatal and putting her on antipsychotics. Okay. One of the very first women that we extubated after ECMO actually turned around to me and said, "What have you done? I had a life before this." Okay, so we may think we've done good, but you've got to think about the woman, yes, but we've got to be kind to ourselves as well. And that kindness to all of you needs to stay as well, but it's quite hard at this time, as you all know. So my reflection in the future is really greater affordability, greater access. Across South East London, we did a piece of work for swabs and COVID, and last March, April, there was an inequity. There was an equity. Depending on what hospital you worked at, you had the swabs at the right time. So I'm all for point-of-care testing and all these tests, but every hospital across the nation needs to have access to it at the same time. I think there was a discrepancy, particularly on our turf. Education and multidisciplinary teamwork is really important, but you can't get that right without a workforce. If you haven't got a workforce, you can't train. And to me, every day is learning. I walk into any place and I'm still learning. Okay, so it's not about the learning, it's my headspace and being kind to ourselves to make sure we continue to learn. So this comes back, and I'm going to walk you through this busy sheet, because we're going to start with the colour thing at the end. And that is not the rainbow of the NHS. It's actually Whitehead's understanding of the social discrimination that occurs in healthcare, and why, if we haven't got the basics right, if you haven't got housing, you haven't got education right, and you haven't got a community to look after yourselves, and then you haven't been able to access that, we're not going to get it right. And that's why socioeconomic 4-5 vulnerabilities is so important, because we've got to tackle that, not just looking after the oxygen. The second is the better births, which we're all pulled towards, yes, and wanting to make things better for women and ourselves. And the maternal medicine networks that are developing across the LMSs and across the integrated care systems, and there'll be 17 across the country, and we should all engage in them and be part of that. We should be making sure maternity is part of that. There should be an obstetric physician, a obstetrician, and also a senior midwife, and there should really be an anaesthetist as well to help you across your sector, working together, not solving everything, but working together to make it better. There are learning opportunities, so you know about Baby Lifeline and all the wonderful work they do. And Yorkshire and Humberside, big shout out to them with the maternity enhanced care and the scorecard they've made across their sector about ITU and obstetric emergency admissions across their hospitals, and learning from there. So I think that should actually become national and not just be sitting there, and we're trying to work on that. So I want to finish now, and my key messages are equity of access to healthcare and resources to everybody in a timely fashion, prevention is better than treatment. So vaccination, but any deteriorating pregnant woman, think about how you can actually prevent it right from the beginning, not just prevent what happened because of the deterioration. When you do your root cause analysis, when you reflect on what's happened, could there be something you could have done 9 months, a year earlier, including pre-pregnancy counselling? Duty of care for me always lies with the mother. Obviously, the baby's important, but we've got to make sure we've got the woman engaged and her family. Don't delay any investigations. Shout out that things need to be done in a timely fashion, and work together as we are today, locally, regionally, and nationally, and use all the resources. Thank you. Thanks.